Thank you. Dr. McLean, before the short adjournment, we were looking at the document which set out what the PHA's intended role was at the outset of the pandemic. I just wanted to finish off quickly, if I may, on that. I think we were looking before the break at the point at which it said provide timely and accurate information. So we dealt with that. And we dealt with ceasing measures. And I think you said that it was possible that the PHA didn't have that role. And I think as things transpired, it didn't have that role, did it, as time moved on?
I think that for something that wasn't on the scale of COVID-19, so something that was a much more limited outbreak, something a bit more usual, if you had an outbreak across Northern Ireland of something else, and quite often in an outbreak your overall objective will change through the course of the outbreak. I think if it was something more on what we would call a more normal scale, that may have been appropriate, but given what subsequently happened over the coming week to 10 days, the scale of COVID, I think, made this quite a different scenario, even from perhaps what was expected whenever the terms of reference were drafted, which I think, from having looked at it just before lunch, was around the start of March.
Yes, absolutely. I'm going to come on and just ask you generally about these terms of reference, but just to finish off on this. So at that time, and again, just focusing on early March, it was foreseen that the PHA would lead on the public health response, correct?
Yes. And
that it would lead the case management cell.
Yes.
And that it would undertake community surveillance, and that it would provide, I'll cut through this, mortality surveillance as well, yes. And that it would also have a communications programme.
Yes.
And I think it's right that very quickly it must have been realised that the PHA just wasn't constituted to carry out a number of these functions. And we'll look at some of the functions that it did exercise during the early period, but I think a number of these things effectively fell away and became the responsibility of the Department of Health, correct?
I think that's correct, and at a strategic level, even beyond the Department of Health, really at a UK-wide level for some of them.
So I'm just going to look then at some of the things that the PHA was doing at the outset. Now, I think what you said a few moments ago was that the core role, as it were, of the PHA is to provide the surveillance about the transmission of a disease when there is an outbreak.
So that is one of our core roles, is to provide infectious disease surveillance. That's one of the things that we were set up to do.
And I think it's right that from the outset of the pandemic, in fact, the PHA faced real challenges in its ability to access data so that it could provide that information onwards to the Department of Health about the transmission of the disease. Is that correct?
I think this was, first of all, it was a brand new infection. Yes. So if it had been something like, and I'll use the example of flu, had it been a typical flu, something that we have systems and mechanisms in place with our laboratories to count cases, with our GP colleagues for them to provide us with information about the number of people they are seeing with flu-like symptoms. There are pipelines and approaches that are in place. COVID was a brand new infection, and so therefore there weren't any ready-built things even within our lab to run the test. That was something that had to be developed. And the pipelines and the channels were new. It was because it was a new disease.
That's, if I can just focus for a moment, because that's really what I want to get to and try and understand. At the outset of the pandemic, so I mean January, February, March time, in terms of the sources of information available to the PHA, I think, am I right in understanding that you had access to Apollo?
Yes.
So that is a mechanism that works for the reporting back of some information about flu data. Is that correct?
That's correct. So Apollo is a system that is used, I think, across the UK, and PHA started to use it in 2009 around the time of the swine flu outbreak, and Apollo it has subsequently been replaced, or is in the process of being replaced, but it gave information around flu consultations in general practice. And that's for flu, that's a really useful barometer of how many people in the community are experiencing flu-like symptoms. So in the wintertime, just because it happens that more people get flu-like symptoms. So it's important that we're able to understand how that is progressing in the community. We don't have widespread testing for flu in the community, so we do depend on looking at how many symptomatic people are seeking healthcare, and that primarily for something like flu is with primary care.
All right, so presumably then that's of limited use.
Yes.
Because it's only telling you who's going to primary care,
Yes.
reporting symptoms of flu. So it in no way gives you an accurate picture of who might be reporting with a different virus.
That's right. So it looks for flu-like symptoms. So whenever they go to see their GP, GPs have very good electronic systems. When you go to see your GP, they will put stuff on their computer. And if they are coming in with symptoms that are typical of flu or another respiratory illness, that's what it will pick up. But it is limited to primary care. And I think some other parts of the UK have, and that's called syndromic surveillance. So syndromic surveillance is people who have the syndrome, so people have symptoms. It's not based on laboratory data, it's based on symptoms. It's called syndromic surveillance. At the start of the pandemic, we had that in primary care through Apollo, but we didn't have it in secondary care set up within EDs. And I think that is mentioned in the statement. Some syndromic surveillance had been set up at a point in time in the Public Health Agency, but that wasn't in place certainly at the start of the pandemic, and I don't fully understand the reasons why that stopped.
All right. Let me just take it in stages, because I think as well, according to your statement, that you didn't have any method of identifying hospitalisations with COVID-19, and you weren't able to trace hospital-acquired COVID-19 until May of that year as well.
Can I just check the paragraph number?
Yes, it's paragraph 282.
Sorry,
Paragraph 282. And just so that I can orientate you in your statement, this is your entire section on data.
Mm-hmm. Okay.
So that would appear to be right, wouldn't it, from your statement?
Yes. I think earlier on in the pandemic, there were a number of things that were built to allow the surveillance team to count COVID-19 positive tests. So the first thing I think that they established was a reporting link with the laboratories. So the laboratories would tell them how many positive COVID tests there were. And in the very early days, that number was very low because testing was limited.
Yes.
So the first thing that would have been built would have been a feed from the lab. It's then a step beyond that to be able to link the feed that comes from the lab with electronic information from the patient administration system, which is the hospital system. That involves an electronic linkage. It wasn't something that was well developed within the agency at that time. Whenever the Public Health Agency was set up, the infectious disease surveillance sat within the agency, but the analysis and use of the hospital data, which includes admissions data, discharge data, that actually sat within the Health and Social Care Board. So their staff in the Health and Social Care Board were much better at using those electronic systems, and they're not simple. You know, it does require experience to negotiate it or to understand it. So they were in two different worlds, if you like. And I think it did take some time for the laboratory information to be able to sort of link and cut across, so you could see how many people in hospital had had a positive test.
I mean, the point that I'm trying to get is it's really just to understand in those early months how it was that COVID was actually being measured in Northern Ireland, because I think it's right that in fact testing was extremely limited right up until March. Mm-hmm. And that a very small number of people had been tested even by, I think we get to around the 7th or 8th of March, and the numbers of people who had been tested was small. Mm-hmm. how was it up until that point, or what was the most reliable barometer of what COVID transmission rates were like in Northern Ireland?
So I don't think we did have a particularly reliable barometer at that stage. We were building links with the laboratories, so we were getting reasonably accurate information from the laboratories. But as you say, that was really only the tip of the iceberg, because only a very small number of people were eligible for the very limited number of tests at that stage. In terms of deaths, for example, because that is mentioned on the in the terms of reference document, and it's also mentioned in the evidence. To the best of my knowledge, prior to COVID-19, deaths were not reported to the Public Health Agency for us to publish data on.
Yes.
We would have been aware of deaths, say, for example, from meningococcal disease or another infectious disease, and we would have that information for ourselves. But to the best of my knowledge, we never received information routinely on deaths, and we didn't publish information on deaths. That was the role of the Northern Ireland Research and Statistical Agency, NISRA.
Yes. So there's a few things bound up in that, if I can just tease them out a bit. So obviously the silver had been stood up from the January. Mm-hmm. Can the inquiry assume then that between the January and until we're getting into the middle of March, that the work done to build up testing capacity hadn't taken place within the PHA?
So testing capacity was ramped up primarily. Public Health Agency does not run testing. Yes. Testing is delivered first of all it was the virology lab in Queen's University, or not in Queen's University, in the Royal Victoria Hospital. Yes. The regional virology lab very quickly actually got a test. So remember, this was a virus that hadn't existed 6 months previously, so the virology lab in the Royal was actually quite fast in UK-wide terms in getting a test that was in place. A lot of work then did go on, and one of my colleagues in the Public Health Agency chaired the expert advisory group on testing on behalf of the Department and of Health. That group sat within the Department of Health but relied on specialist skills from the PHA, and the remit of that group was to advise on testing and to be involved in the ramp-up of testing. Testing went from not being able to do any tests at all, sort of at the start of the year, to by the end of the year doing hundreds of thousands of tests. Yes. And that was way beyond the capacity of the health service. And you'll remember that we had the National Testing Initiative come in, so there were lots of different partners involved. There was the Royal. There was also the universities, AFI.
Sorry, Dr. May, I'm just going to stop you because I am really just focusing on the outset and really just trying to understand what work had been done within the PHA. And I understand the PHA wasn't in fact administering the testing by itself, but just trying to understand the work that had been done in those first few months on the understanding that there would have to be a test and trace capacity that didn't exist. What your understanding is of the work that went on in that first bit of time within the PHA. So
because I wasn't physically there, I'm really not over the detail of that, and I don't want to misrepresent anyone by maybe not describing something that happened. I haven't seen the note of every single silver meeting to be able to describe any discussions that took place about ramp up. I think ramp up was very quick, perhaps in hindsight and learning for a future pandemic. I would say that it is much more obvious to us now that testing capacity and the rapid expansion of that at the start needs to be a priority, and that is something that I would expect will be built into plans. But that is learning.
All right.
But perhaps if it's acceptable, if I undertake to look at the notes and provide the inquiry with any additional record that I can find of specific actions that were taken by Silver at that time.
I anticipate there'll be other witnesses who can help us with that, and I'll take you through to some other documents shortly that might help, but I just wanted to go to this first so that we could understand some of the practical difficulties there were at the outset. This is INQ 00045513. And if we could go to page 2 of that. And again, I think you've been provided with this, Dr. McLean. This is an email that was sent by one of the advisors to Minister Swan. And it's one of a number of emails at around this time that were sent to the PHA, setting out the difficulties. And I think the Minister had taken a personal interest in trying to ensure that he was providing accurate data whenever he was making announcements or speaking about the pandemic. But we can see that at the second paragraph, what the advisor was saying was that there were serious discrepancies in what the Minister is being told and what's actually happening. I continue to have serious concerns about the quality of information being published in the daily PHA surveillance report. And then there's a reference in the next paragraph. I think the Hugo is Professor Hugo van Woerden, is that correct? The Minister and I both asked for clarity yesterday, and with all respect, we didn't get it. I was even told yesterday that it's not the time to be getting into the detail. It is. And then he sets out some of the other issues that had been raised. Can you help the inquiry with that? I think it is right that there were real difficulties at that point in time with the PHA's provision of information to the Department of Health and to the Minister in particular.
So because I recognise that this is going to be an issue that was going to be of particular interest, I have taken the opportunity to talk to some people who were involved, because I was not involved at this time. So my understanding is that a lot of the difference and the perception of discrepancies in the numbers was around the difference between the total testing capacity, the absolute maximum number of tests that the laboratories could run, versus the number of tests they actually ran. So having looked at documents that were provided by the inquiry around this issue and having talked to colleagues who were directly involved, what seems to have happened is that around about just before this date, which was Sunday the 28th of March, but just before then, I think an announcement or it had been put into the public domain that our total testing capacity in Northern Ireland was now 600 tests per day, which is a huge increase from what we've talked about earlier. And then I think there was frustration and disappointment expressed whenever the reports in the Public Health Agency were coming that, well, we did maybe 380, 400 tests, and that number was fluctuating from day to day. I think that the issue has arisen because there are two different things at play here. There's the total number of tests that the laboratory can physically do, and then there's the total number of tests that the laboratory receives, and that's really the demand, the number of people who are coming forward to be tested. It seemed counterintuitive at the time, because there was such a clamour for testing, such a demand for testing, that information was being put out that there are now 600 tests a day available, but only 300 and whatever it was. Right. People came forward, and I think there are a number of reasons for that. Testing at that stage was limited in who could come forward. Healthcare workers had now been prioritised, and that was to make sure that they weren't bringing the infection into work and to make sure that they could safely return to work with symptoms. So they had been prioritised, and I think there was a frustration that we still had healthcare workers off work, but not all the tests were being used. And I think at that stage, the number of testing centres was limited. So I think there were maybe two at this stage, one in the SSE and one maybe in Derry. So the number of people who came forward were that number. And people might not have come forward for a whole range of reasons. But the number of people who come forward, that is beyond the control or remit of the Public Health Agency. All we can do really is make sure that our colleagues in trusts and healthcare providers know that they have symptomatic staff, that they are eligible for testing, and they should come forward. And I think it was the difference between those two numbers.
So there was a there was...
That is, so because I wasn't there, I can't be absolutely certain, but having spoken to people from PHA who were there and having looked at the various emails and documents, that seems to be the issue, that there was a frustration, that there was a public announcement made that there were 600 tests available now, but a much smaller number of tests were actually being performed.
Because I was going to ask if we could go to a document that's related to this. I think it's page 1, sorry, it's page 1 of that document. Yes, because we have the Minister, in fact, stepping in now to say that the PHA and their reporting needs fixed and fixed now. This is now a millstone around our necks. Can we pull the daily surveillance report into the department? So, I mean, plainly the issue is around the Minister being concerned about the accuracy of the information that he's providing. And did that in fact happen? Did the surveillance report then go in? Was that taken into the Department of Health? So
I can't comment for the Minister or what his frustrations were at that time, so I may be incorrect, but what I have seen in the documents was, I think it was the mismatch between the tests available and the tests actually being done. Yes. PHA accurately reported the tests being done. The fact that they were not the same as the 600 tests available seems to have been the issue.
Okay.
Did the surveillance, I know that some reporting did go into the department. I'm not entirely sure of what exactly went into the department and what remained with the PHA. I don't really understand the exact breakdown of it, but that did happen at a later stage. But
all right, I'm going to go to the PHA response to this. So it's at INQ 0003898110. And if we could go to page 3, please, to begin with. It's just to help orientate you in this. So I think we can see here that the director, just to be clear, Professor Van Woerden was the then director of the Public Health Agency, wanted to have a meeting about it. And if we could then go to page 2, please. And this is from Mr. Pangeli, who's the Permanent Secretary to the Department of Health. And one can see there the frustration apparent on his part and his annoyance that no meeting was needed, it was just clarity. So again, it would seem that at this point, and it's the 28th of March, this was obviously an issue of some seriousness, yes?
Yes, it obviously has been escalated to a very senior level. Because I wasn't there, I really don't want the nuance, don't get all the nuance, I don't want to misrepresent anything. I would make a comment, though, that this was an extremely difficult time for everyone at all levels of society. And I think that people were working really round the clock, and I noticed in some of these emails that they were sent on a Sunday, quite often late on a Sunday. And I think it is... it's inevitable sometimes that frustration will spill into communication, and I can't comment on whether or not a meeting was required. My experience in general is that if there is a misunderstanding and email correspondence goes forward and back, that can sometimes make things worse, and sometimes a discussion to understand the positions is helpful. But I wasn't there, so I don't know.
I mean, I think you will have been able to see from the correspondence that we've sent you, I think that these problems endured. They didn't go away. Perhaps if we could look at another document. This is INQ 0003898819. If we could go to page 4, again, documents just to help you orientate yourself in it. Mm-hmm. So I think we can see that in relation to this, the issue is around the numbers of people who had died and it being part of the PHA's role to report those by this stage as well. And I think if we go to page 4 of this, sorry, it is page 1 of that, I do apologise. We can see that there's a lengthy explanation from Professor Van Woerden about the deaths and how they were being counted. And it would appear from this that there's some resistance on his part to the basis upon which the PHA was being asked to provide information to the Department of Health about the number of people who were dying each day. Is that right?
So this email is dated the 6th of May.
Yes.
I think some of the issues and differences around deaths predate that, and I think it's maybe helpful to go back a bit earlier in the pandemic
Yes.
to sort of explain the story of how I think this unfolded. I said a while ago that, to the best of my knowledge, and I've talked to my colleagues who have a special interest in surveillance, PHA has never had a role in counting deaths, receiving information about deaths and providing public information. That's a statutory duty that sits with NISRA and the Registrar General. So there's a law that you must report a death within 5 days in Northern Ireland. And the causes of that then are set out. And there are lots of rules around what you put on the death certificate, and that is looked after by NISRA, and that's a really important, accurate record of deaths. Because there is an absolute recognition that people will want to know, including the department, including the minister, but including ourselves, we're trying to understand how the pandemic is progressing, how many people are being admitted to hospital, how many people are dying. The surveillance team and the Public Health Agency established for the first time ever a system whereby clinical staff, so doctors and the main consultants in hospitals, could report patients who died in hospital who had had a positive COVID test within the previous 28 days. The positive COVID test within the previous 28 days is a definition that had been agreed with other public health organisations as being the best definition we could use. That used a system called SharePoint, which is a very basic, I think it's a Microsoft program, and it allows you, it's like a portal, so it allows you to put information in maybe in a hospital, and then that will come into the PHA. So the arrangement was, and I think the Chief Executive wrote to trusts, Chief Executives, and asked them to implement this in their trusts. The arrangement was that clinicians would report all deaths that had occurred and patients under their care by a certain time each day. And that would allow the PHA to produce a count. Now, there are a number of challenges with that. As I say, this is the first time anything like this had been set up before. It depended on very busy clinicians who were looking after very sick patients. It required them to go and complete an administrative task. So there's a little bit of a weakness there in that you could get under-reporting for very understandable reasons. You could also get that clinicians maybe didn't get a chance over the course of a couple of days and might report several deaths maybe on one day, but they may have reported on different days. So it was as good a system as could have been put in at the time, but it was certainly not a perfect system, and it was certainly not at the accuracy that we would expect when deaths are being published in the way they are being published from NISRA. I think there was some loss in confidence around the information that was being provided when it started to be used in the public domain and being used as a count of deaths, because there was that risk of under-ascertainment of deaths. There was also a risk that we obviously weren't getting most community deaths, although sometimes I'm led to believe that maybe a GP would have phoned in and said, I've had a patient who's died in the community from COVID. That might have been added into the numbers. So they just weren't accurate numbers that we could really stand over in the same way that NISRA has accurate numbers. And I think there was some anxiety around that, and sometimes perhaps the department would say, well, the Public Health Agency said 3 people died in the Northern Trust on this day, but I know because my neighbour died, and there was just a bit of a shakiness of confidence. But having looked at that, I would say this is because the information system that was put in place was the best that it could have been, considering the circumstances, but it was never going to give totally accurate information that rightly and properly rests with NISRA. So it was almost like it was information, but it wasn't complete information. It was useful information in that it gave you a bit of a trend. You would certainly expect day to day that you would see a reasonable trend, but it wasn't perfect. So I understand there had been some loss of confidence because of the issues, and again, I think it was perhaps misunderstandings and perhaps not understanding the complexity and just what was involved. This email, which is sent in May, and I did take the opportunity to speak to Professor Van Beerden about it, what he meant. This is, I think, relates to a different issue, to the death counting.
Can I just stop you? Sorry, you've spoken at length, and I'm really just focusing on the language that's used.
Okay.
I want to focus on the language that's being used in this email.
Okay.
Because what he sets out in terms is, and it's the third bullet point down, isn't it? The data that's being reported to the public is completely misleading. So he's not saying it's imperfect. He's saying it's completely misleading. And I want to understand your evidence as to whether or not what he was saying in May is that accurate? Is that correct? Was the data that was being reported completely misleading? Because, as you've suggested, it might have been an underestimate.
So I think, I'm not sure, I would need to check this, but I think by May, I think he's actually talking about information that is now being published as well by NISRA.
Yes.
As well. I think whenever he says it's misleading, whenever I spoke to him, I said, what did you mean? I think that what he's referring to is the debate that we heard many times during the pandemic is death with a positive COVID test within 28 days the most accurate way to reflect the number of people who have died because of COVID. So an analogy that used to be used sometimes in the media, you would hear, well, you could die of you could fall and hit your head and die from a head injury just because you happened to have had COVID a week previously. You would be counted in the COVID death numbers. Now, there was a lot of public discussion around that, around what was death from COVID versus death with COVID.
Yes.
And I think what happened then was NISRA then moved and did publish quite detailed guidance on the attributable causes of death. So within the death certificate, you've got various things, and it talks about what the underlying cause is, which starts to try to unpick it. I can't be absolutely sure what Professor Van Beerden meant at that stage, but from having talked to him, looked at the chronology of the various things that have happened, I think that may be the issue. But as I say, I'm not entirely sure.
But should we take it from this, that from that period until May, there were still serious issues or serious concerns on the part of the PHA as to the accuracy of the data that was being reported?
This is the opinion of Professor Van Beerden, so I'm just careful about interpreting it. I think my feeling about this was that he was worried that things were being presented as absolute certainty that this was a COVID death when other things may have been in there as well, right. Is my understanding. And it was that thing sort of dying because of COVID versus maybe having a coincidental positive test within 28 days. That is my understanding, having tried to piece together the various bits of evidence and having spoken to him.
I'm going to move on to ask you, I think you know that there was a rapid review of the PHA's epidemiological function. If I could ask for that to be brought up, please. It's INQ 00001196.
Speaking of the word rapid, I'm afraid you're going to get me into terrible trouble as stenographers, Dr. McLean.
Sorry.
Could you try and slow it down?
And if we could go to page 20, please, and it's paragraph 9.4. I'm sure you've seen this, but this epidemiological review, and this was done at quite an early stage. Forgive me, I've forgotten the date, but I'll come back to that. It was done at quite an early stage, but we can see at paragraph 9.4, it expressly refers to the fact that there were difficulties and tensions around the reporting of the daily death figures. It seems clear from a recent feedback session from this rapid review to the PHA board that there are individuals who attend PHA board meetings who still cannot grasp why it was so important to the Minister and the Department to have exact and reliable figures about the number of daily deaths. This was and is a matter of public confidence and a measure of the competence of the system to respond to the pandemic. So the criticism that appears to be being made in that review was the ability of the PHA to provide the accurate and up-to-date information. Do you agree?
So the review, my understanding, was undertaken by an individual who was a retired civil servant. So he will have fully understood the Minister's and the Department's need for accurate and up-to-date information, and indeed the public's need. And I understand that. I can't comment on his view that he makes about individuals who attend PHA board meetings. I wasn't there. I will not comment. I can't comment on that. I think the report is titled "A Rapid Review of the Epidemiological Function of the PHA." And what I've been trying to explain is that prior to COVID, PHA has never had, and even now still does not have, the primary responsibility in reporting death numbers. That lies with NISRA, and it lies with NISRA for the reasons I've tried to explain, that it is a complicated system. I think my colleagues in the PHA in surveillance, I think they did an excellent job working with the trusts to put in place a system where trusts could report deaths. The only way that we had at that stage was for people to report them. Other layers that were subsequently put in included linking death, the fact of death, to information on the patient administration system. Even that method is not 100% accurate. The definitive source for reporting of death numbers is still NISRA. But that there is an obvious lag there, because I think you have up to 5 days to register a death. I think the median's about 3, and then there's a process of checking. And I know that subsequently, or that during this period, I have seen in the evidence that the Department of Health had asked NISRA to report on a more frequent basis, to report deaths on a more frequent basis. They were asking PHA for it daily. I think they'd wanted NISRA, because they recognise that NISRA are the accurate source of death information, to report it more frequently, maybe twice weekly. And NISRA then wrote back and explained why that wasn't possible for them. So I think the challenges, while it might seem like a simple thing to do, the challenges of accurately reporting deaths are not insignificant.
All right. And that report was in July 2020,
Okay.
just so that we have that for the record. And I think what it suggests, and we can see this if we look, for example, at paragraph 9.5, that again reflects the concern that there about the ability of the agency to understand the department's requirement for information, including the required frequency. And I won't read out all of this, but it goes on at paragraph 9.6 again to consider those difficulties, and then goes on at paragraph 9.7 to set out a number of challenges which the PHA faced in being able to provide the sort of information that was being required. Correct? And it went back to the issues that I asked you about at the very outset. In other words, was the PHA adequately staffed in order to be able to provide that sort of service to the Department of Health? Yes.
It does. And I think we've talked about staffing issues. We've talked about staffing issues at consultant level. But public health is a multidisciplinary effort. In fact, it's a multi-agency effort. The PHA can do really nothing on our own. We need to work with lots of partners right across society. But in terms of staff numbers, we did have a very small surveillance team as well. And surveillance is a skilled task. So there are surveillance scientists who we employ who are really good and skilled at understanding information coming in from laboratories, understanding what a case is, and lots of caveats with data. So I think there definitely was a shortage in the number of people who were employed by the PHA with those sort of skills. That has been addressed to some degree. I think another area that required development and that is being developed now is our ability around automation and our ability to use digital data and things. So we have, over the course of the pandemic, PHA has really developed capability and capacity around digital analysis.
I'm going to stop because you're rushing ahead to issues that I'm going to come to. I just want to go through some of the tasks or functions that the PHA was asked to exercise in order to understand whether it was capable of doing them. One of the other tasks at this early stage as part of the stand-up of the silver arrangements that the PHA was asked to do was to partake in surge planning as well. And I think, again, PHA was asked to do that in conjunction with the board as well, correct?
Yes, the Health and Social Care Board.
Yes. And again, the evidence seems to suggest that there were problems, I think, on the part of both bodies to be able to provide that in a timely way as well. Is that correct?
I think it was a challenge. I mean, as we keep saying, this was an unprecedented event that happened. And yes, I think it was a challenge to actually be able to, at speed and scale, provide a surge plan that would meet the needs of the population of Northern Ireland. And one of the things that I think we forget 4 years on is really the lack of knowledge that we had. Guidance, information wasn't just changing day to day, it was changing hour by hour. So really, it was very difficult to know what it was that we were planning for. I remember people were not sure about the duration of the pandemic. Would there be, I think initially there was a general feeling that there would be one wave and it would be a bit like flu. You would have one big wave and then sort of a series of smaller waves fizzling out. This played out in a very different way, but it was the surge planning I think was challenging as well for a lot of reasons, including the ones I've talked about.
We've got some witnesses who can deal a bit more detail with surge planning, but I think it's also right that the PHA didn't have any modelling capacity either. At that time, you had no modelling assistance.
The PHAs did not have any modelling capacity, and as I said earlier, our development in more digital analysis, data science, was behind what we would have ideally liked. We've done a lot of work to improve that, and I think at the outset we talked about the change or the number of health protection consultants we had, but the PHA had also been without a permanent chief executive from 2016. I'm the 5th director of public health I think since the pandemic started. So that instability in leadership and uncertainty around what the future for the Health and Social Care Board would be, I suspect that probably did not help sort of future planning, strategic planning, horizon scanning.
Yes. I'm going to move on to the next part of the role, which was obviously surveillance. Now, we know testing is an important part of surveillance, and I think it's common ground that there was just very limited testing capability up until about the middle of March. Is that...
So it ramped up, I can't remember the exact times, but it did ramp up very, very quickly.
I've certainly picked out from one of the documents that was in your bundle, and I won't take you to it, but in addition to that, the number of cases that were actually being confirmed was quite low as well. Is that correct? And certainly one of the figures that's mentioned is that by the 7th or 8th of March, there had been 8 confirmed cases in Northern Ireland. Is that correct?
It sounds, I can't remember exactly, but it sounds about right. Yeah.
So just then looking at the tracing capability, because that was held within the PHA, yes?
Yes.
But I think, as you set out in your statement, that was also extremely limited as well. Is that right?
Yes. In the early days of the pandemic, we had a very small number of cases, and the cases at the very early days, it tends to be the case with things like this, were imported cases because they were coming in from elsewhere. So we had a small number of cases, and the strategy at that time right across the UK was to identify the cases which in the main were coming in. They were imported cases because the outbreaks were in other countries. And was to identify those cases, isolate them, isolate their contacts to try and slow down and prevent further spread. That's quite an intensive job whenever you're doing it for a prolonged period of time. So what happened in PHA, which is in line with our plans, is that other people, so health protection, the health protection part of the director that we've talked about, were initially in charge, and then they started to bring people in from other divisions, redeploy people in.
I'm just going to stop you there, because obviously we know when we get to the 12th of March, tracing stopped in Northern Ireland. I think what's less clear is whether or not the Public Health Agency had at that point gone beyond its capacities in terms of being able to carry on tracing, or whether you were still at a point where you could have carried on doing that at that time.
So I was involved in tracing at that stage because I had been redeployed over to help with it. I think that it was a challenge because it was very intensive and it required us to work very long hours, 7 days a week, and bring lots of people in because of the labour intensiveness of each one. I think that we had gone into a rhythm. I wasn't working at director level at that stage, so I don't know what the corporate position was, but certainly on the ground, involved in it. We technically probably could have kept going for a bit longer beyond the 12th of March. I think there's a separate discussion around the utility of that. Would it have been worthwhile? I think in theory we could have kept going. It wouldn't have been without its impacts on the staff well-being. It was hard work.
Right. But is it right that still at that stage there wasn't actually a clear picture as to what the prevalence was in Northern Ireland?
So at that stage, people who were being tested were people who had returned from other countries or people who had been contacts of cases. I think, and I can't remember at what point it was in March, maybe about the 8th, we started to see cases that were locally acquired. So they had and hadn't had contact with a case we'd known from outside. So at that point, we had some level of community transmission in Northern Ireland. So at that point, we certainly had gone beyond the point that we were going to contain it to only imported cases. I think that is true. Could we have continued contact tracing for a few more days? Arguably, yes, we probably could have. Would that have stopped the pandemic in Northern Ireland? No, it wouldn't, because we already had community transmission.
How many people were involved in tracing at around that point in time?
So I would need to refer to the rotas and things we had.
Can you give us a rough idea?
So I'm from memory here. We were running 7-day service. We were running it from about 9 to 8 in the evening, and in any particular time there might have been, this is a total guess, maybe 20 or 30 people in a room. So, but many more people contributing to rotas. But that is something that from our records I may be able to give a better idea. We're mainly relying on redeployed staff from other parts of the PHA.
I want to move forward, as it were, because obviously efforts were then made to ramp up test and tracing. And I think you know that there's an issue about the information that the PHA provided about the capacity to expand the number of tracers who would be available. If I could ask to be brought up, please, INQ 000353669. I think we need to go to page 7 of this, please. Oh, no, that's fine. And we can see that this is an email, again, from Professor Van Voorden, And he's writing, isn't he, to the Chief Scientific Advisor. This is on the 20th of April, to say that over 500 contact tracers who had been identified and were being trained. And I think that that's in reply to an email from the Chief Scientific Advisor. We might just need to go up a bit if we can, please. Yes, it's the email that was sent at 9:18. Yes, so it's in response to the Chief Scientific Advisor saying that contact tracing and testing was likely to be a key component of the strategy going forward. Yes.
Mm-hmm.
Can you help? The evidence of the CMO and the CSA is that that information was what they understood the position to be, that there were 500 people who were being trained. Was that in fact the position?
So again, this is an area that I've had to look into and speak to people around, because I wasn't there. I have spoken to people and tried to understand where the 500 figure came from in Dr. Van Beerden's email. I think it may have related to, at that point in time, there had been a suggestion that 500 environmental health officers, or people who were working in environmental health officers who weren't really doing environmental health things because restaurants and things were shut, could be loaned into the PHA to help with contact tracing. That seems to possibly be where the number 500 has come from. Those staff did not come across to the PHA, and to the best of my knowledge, at this point in time, in April 2020, that number of people, 500 people, were not being trained. It was a much smaller number. Over the course of the pandemic, how contact tracing was approached and delivered changed. I've liaised with colleagues who were involved in the operation.
I'm going to stop you, and of course it's understood this is not your email to answer for, but I think what you're saying is it was not the position that 500 people were being trained, and that the email is misleading in suggesting that.
At that point of time, to the best of my knowledge, 500 people were not being trained.
I want to just stay on this, if I may, and ask if another email could be brought up, please. This is INQ0000353671. And we see, yes, thank you. We can see again, I think we probably need to go to the next page if we can to orientate ourselves. That again, it's from Professor Van Voorden, and we can just see that he's setting out, we're obviously a bit later in time, it's gotten to the autumn, and Professor Van Voorden is setting out that Professor Young had indicated that the PHA would need to be able to manage 500 cases a day and 5,000, I think that's probably contacts a day, and that this would require 300 to 600 staff. And I think if we go to the very bottom under reflections, he's effectively saying that he would have to double the size of the PHA, so that effectively that was just not realistic. Is that correct?
I think, again, not my email, but that would seem to be what he was suggesting.
And I think if we could go up, please, in this email chain to page 2. Thank you. The email at the top is from, we can just see, from the Chief Medical Officer. And he says, perhaps Groundhog Day for PHA. And DPH, can you help me as to who DPH is, please?
So that would have been Professor Van Beerden at that time.
Thank you. And what he says is, we provided this modelling update to PHA in March or May time at a meeting in Castle Building, which Liz and I attended, and at which Hugo was present. We experienced significant incredulity and pushback from PHA colleagues, as I recall, when challenged at the time, and we have repeatedly challenged since. And then he sets out that he had in fact directed PHA to double their contact tracing capacity. So again, Dr. McLean, just taking his words and his reference to incredulity and pushback, was that right? Was there pushback on the part of the PHA? And again, understanding that you were not the director at that time,
So
about the extent of contact tracing that would be required.
So I wasn't the director at that time, but again, I've tried to explore with colleagues who were there what this referred to. I think that there may have been individuals who were involved in planning the contact tracing service. I wasn't. Who felt that between 300 to 600 contact tracers was a very large number to trace 1,000 cases a day, that you wouldn't have needed that many. And I think at various points in emails, an ECDC document is mentioned where it sets out some different scenarios for the type of staffing you need. And it would depend on how long you took per case, how long it took to contact whether or not you used digital self-trace, SMS message, all that sort of thing. So it wasn't a very fixed number. I think that the difference in opinion may have been around the number of staff required to trace that number of cases a day. But again, that is from the discussions and what I can ascertain has happened.
Because it's not a disagreement, I think, in this email.
Yeah.
The Chief Medical Officer is saying that he had directed PHA
Yeah.
to double its capacity and that hadn't been done effectively. Do you agree?
I think that that seems to be a fair conclusion.
But is there also an issue then as to whether or not the PHA just had that capacity or ability at all to ramp up in order to be able to provide that level?
I think that very quickly after this, there was a period, I think in late September, early October, where PHA capacity to keep up with the number of cases and satisfactorily trace them and complete them was challenged. And having looked at the activity data for the service, I can see that there was a period where on many days we weren't hitting the sort of 80% of cases done that we would have wanted to. I think then changes were made and the model was changed or the model was further improved. I'm not sure operationally exactly what happened, but very quickly the number of contact tracing hours that were available increased really rapidly, and then once that was in place, so I think I think it's fair to say there has been an issue for a period of time where perhaps a course of action was taken and we ended up in a situation where capacity was not enough. It was rectified pretty quickly, and I think I would just want to acknowledge the efforts of people within the PHA who did ramp up a huge contact tracing service. And I know that because I've asked about the number of staff who were involved. And I think rather than talking about individuals or whole time equivalents, we learned that actually planning the number of tracing hours you needed day to day was more helpful. So, and they were planned based on the number of cases that we expected to get, and that worked much better, sort of beyond the middle of October. But I did ask, but how many staff actually did we have? And over the course of the pandemic, I'm told around 600 staff were trained in contact tracing. Not all of them traced all the time. Some would have only traced for maybe a small number of days, a very busy period.
So that was the eventual position.
Eventually we got to 600. It wasn't 600 whole-time equivalents, but it was across the pandemic. In total, at different times, we had 600 people contributing to the contact tracing hours.
I want to go to another topic, and it's an important one. I'm going to try and take it as quickly as I can. You were obviously involved in care homes and I think controlling outbreaks of Covid-19 in care homes and providing advice. Is that correct?
So I was involved in working primarily with colleagues in nursing and social services around trying to put some measures in place that would support the sector in a number of ways.
All right, and I think it's right. This is a matter for a number of another witness, but the guidance that was given by the Department of Health at the very outset of the pandemic was to the effect that capacity in hospitals should be freed up by making as much use of care homes as possible. Is that right?
So I believe that would have been the position. I think there was a real concern early in the pandemic that hospitals were going to very quickly be overwhelmed. And I think you may be referring to a letter sort of preparing the system for COVID. And I think there's also reference in that letter to perhaps almost field hospitals, real concern that we would run out of capacity in our hospitals to look after all the people who needed to be there. So I think the driver there is that we need to make sure that the people in our hospitals are people who could only be cared for in a hospital. And I think that's where that comes from, perhaps.
Yes, so I think we understand the rationale for it, but the direction was to utilise as much spare capacity in the care sector
seems to be the direction
as was possible. And can you just help me then in terms of the testing of people who were going from hospital into care homes? Certainly from the material, and I think that it's in your bundle, I think initially at least, was the direction given to care homes that they should test people who were symptomatic within the care home?
That is my understanding. That's not the part of care homes that I was involved in at the time. Testing policy was being led by the expert advisory group on testing, but I think testing at that time was being reserved for symptomatic people.
Yes, it in fact took a considerable period of time, didn't it, before there was asymptomatic testing within care homes?
It did.
I think that it was raised first of all in the April, is that right? Or guidance was suggested in the April that there
I can't remember the dates exactly, but I know that I think it was recognised that care homes were a very important place to get testing into and available to. And I think then there was a plan, and it was around Easter, which is possibly early April from what I remember, that testing started to go into care homes. And I remember that we did have an initial round of testing after testing for the asymptomatic or the symptomatic cases. There was work to sort of establish how feasible it would be to go into a care home and test every single resident and every single member of staff, because while that's something that became very normal during the pandemic, at the outset there was very much, would that be acceptable? Would it be fair to go round and test every single resident? Would it be fair to test all the staff? So eventually we did get to a position by sort of testing that was possible first of all. Then we rolled out testing, starting off with a single round of testing from memory in homes where there had been an outbreak.
Yes.
And that was around into them first, then also homes who'd never had an outbreak, and then the regular programme of asymptomatic testing, which I think remained in place possibly for the next year, 18 months, then came after that.
I think it wasn't until the November that there was weekly testing within care homes of asymptomatic people. Does that accord with your...
I think regular testing started, I can't remember the dates. I'd need to see my timeline, which I don't have. But there certainly was a round of testing which completed, I think, by the end of June. And then there were recommendations about introducing a regular testing programme. Prevalence in the summer of 2020 was very low. Testing residents is, and we were very conscious of this, testing residents, anyone who had a COVID test will remember it was quite unpleasant. So you didn't want to test people unnecessarily. So I think that the testing during the summer was less frequent, and then it was increased in frequency perhaps in the autumn. But I think regular testing started in the summer, but I may be incorrect.
But just if we stick for the moment at the outset of the pandemic, so looking at early spring, I think it's right that the growth in cases became, and you've said this yourself in your statement, that most of your work from the March onwards was dealing with outbreaks in care homes. And I think we've seen already in the data that the highest number of deaths in care homes in Northern Ireland was in April 2020, correct?
Yes.
And in terms of the role of the PHA in dealing with that, I don't think that any of your staff were able to actually go into homes to observe whether or not or what testing was taking place, or what separation there was of people who were infected from those who weren't?
So the role of the PHA, so PHA has a role in supporting care homes. And before the pandemic, the sort of outbreaks we got, the more common ones would have been GI, sort of gastrointestinal outbreaks, but we would have had a small number of respiratory outbreaks every year. And whenever a home had some sort of outbreak, our nursing colleagues, primarily our nursing colleagues within health protection, will work with the home to give them advice around infection control, isolation, all the various things that to manage an outbreak. While we didn't go into care homes routinely during the pandemic, we did have a programme of education and learning that would have happened before the pandemic and actually continued on during it. I do think that in those weeks in April, where there were obviously lots of outbreaks with very high mortality rates, in care homes very high attack rates. We worked collectively with nursing and indeed colleagues in the department and other places to try and put in place a range of measures that would help the care home sector. I do recall a letter that was issued, I think, jointly by the Chief Medical Officer and Chief Nursing Officer. It wasn't in my bundle, but I do remember this letter was issued. PHA, we don't have a team of infection control nurses who would routinely go out and perform inspections and support that sort of setting. At the time we didn't. And I remember the letter that went out from the Chief Medical Officer and the Chief Nursing Officer asked trusts who would have more capacity in this sort of area than we did to make sure that whenever there was a care home outbreak notified, we would tell trusts, and then the letter had asked trusts to use their care home support teams and their IPC, they will have a knowledge of the home and to go into the home and observe practices if necessary. And I think that is in a letter which we can find and supply.
I'm going to move on, if I may, to another.
Just before you do, and I'm sorry to take up some of your time, Ms. Dobbin, you seem to have moved from testing on discharge from hospital to testing in care homes of residents and staff. Could I just check, what was your evidence on testing on discharge from hospital? When did any testing on discharge from hospital start, roughly?
I'm sorry, I can't answer that now. I would have to check that and come back. I can't remember.
Initially, it was for symptomatic patients.
Yes.
Do you know when, if at all, testing for asymptomatic patients on discharge from hospital started?
I'd have to, that definitely did come in, but I'd have to check the date that actually started. I'm not sure.
And finally, on this subject, and who was making the decision as to when testing would occur on discharge from hospital?
So my understanding is that advice on testing was considered by the expert advisory group on testing. That was chaired, as I said, by someone from the Public Health Agency on behalf of the department. That group included public health people, it included virologists, it included infection control people, and they provided the best advice that they could come with collectively, and they provided that advice to the department. Their role was to advise the department then on testing policy. So testing policy was policy that the department made, is my understanding.
If you can find the dates, I'd be really grateful
Okay.
for the symptomatic and asymptomatic, because its practice seems to have varied around the United Kingdom.
Yes.
Okay.
I mean, what we do have, but it may be that the CMO, I think, will be able to help us on this if you
Yes.
don't have the date to hand. But I think certainly what the Department of Health suggests is that from the 12th of April 2020, Covid-19 testing arrangements were put in place for all symptomatic residents and staff in care homes. So that's not dealing with the hospital, that's dealing with the care homes. I don't want to put you on the spot if you can't remember any specific dates.
I can't remember exactly. It sounds roughly right. It was, I think it was post-Easter, and I think Easter in 2020 was early April.
All right. I had wanted to ask you about one more specific and discrete area, conscious that we're under a time pressure. It's really the role that the PHA has in health inequalities as well. Now, in terms of its broader remit, it has both a health inequalities role and a risk assessment role as well when it comes to outbreaks of disease. at any stage, and I'm thinking in particular about the early stages of the pandemic, did that role intersect, as it were, so that the PHA was providing guidance, for example, about the particular risks that might accrue to disabled people, whether because of their clinical risks to COVID-19 or more generally because of the risks that disabled people are at in terms of their health? I hope that makes sense.
Yeah, no, it does. So I think I can't specifically remember what advice we might have given to disabled people. Are you thinking about shielding or?
It's not necessarily advice. I think it's trying to understand whether or not the PHA played any sort of broader risk assessment role about the particular vulnerabilities, for example, of disabled people in the community and helping to inform decision making. So because of its very particular remit.
To the best of my knowledge, in those early stages of the pandemic, I don't think that we did do a lot of that. I hope I haven't misrepresented work that maybe went on that I'm not aware of. As the very early stages, there were lots of things going on. We were getting used to remote working. It was very, I think for most organisations it was hard. Certainly later on in the pandemic, there was very much a recognition that I think was probably obvious from the outset. I mean, in Northern Ireland, we have, like many countries and like the rest of the UK, quite shocking health inequalities. Particularly, you know, if you think about 2 boy babies born in a hospital in Northern Ireland today, one born to parents from an affluent area, one born to parents from a very disadvantaged area. At the moment that they are born, their life expectancy differs by 5 years. 2 newborn babies, that's unfair. And that is unacceptable. And that is the situation that we went into the pandemic on, that we have those inequalities. And I've used an inequality that was between disadvantaged groups, but also disabilities, ethnicity, gender, lots of other things cause inequalities. I would say at the start of the pandemic, do I think that we looked at as much as we could? No, I don't. And I think that is learning for the future, that we have to be so conscious of those pre-existing health inequalities and how we mitigate in future. I would also say, as Director of Public Health, that this is not just about the pandemic. It is unfair that we have those health inequalities in our society. The Public Health Agency, and indeed the Health Service overall, cannot fix those. 80% of those are about how much money people have, their level of education, and I think there is an absolute onus on society and on the executive and on government to realise that these are unfair inequalities that need to be tackled, not just because they caused an issue in the pandemic, but just because they can and should be tackled. And I think if there is anything around the executive and around coming together, that is a message that I think that we need to go in. This is not just about pandemic preparedness. This is about health inequalities in a broader sense. But coming back to our role in PHA, I would say that as things went on, I mean, I've explained that we have a health improvement team who were involved helping us with doing many of the health protection type things at the start, that we recognise that they have particular skills and particular contacts. And I've said earlier that the Public Health Agency, we can't do anything by ourselves. We need to have partnerships at all levels of communities, right down to sort of grassroots community level. And I think where that team really did make a difference was the connections that they had and with councils, the connections they had perhaps with groups of migrant workers, the community groups who represent them. And for example, we had outbreaks in factories that have lots of migrant workers, trying to go in there, explain isolation, eventually explain vaccine, trying to make sure that vaccine came to them. We did do work in that later on, but in the early days, and particularly thinking about perhaps people who were disabled or had faced other types of disadvantage, I think that is something that I hope I haven't misrepresented and missed things that we did, but I think it's something that I would want to improve on for the future.
I'm grateful to you. Those are all my questions, and I understand there aren't any other.
I don't know how much of your thunder Ms Dobbins pinched, Mr Freedman.
None of my funder pinched. I want to thank her for asking the questions and the answers that have been given by Dr. McLean. No more questions from me.
Thank you, Mr. Freeman.
Thank you.
Very well, we'll break now. And so thank you very much for your help,
you.
Dr. McLean.
Thank you.
And we shall return at 3:15. Mr. Scott.
Good afternoon, my lady. May we call Dr. Jenny Piper?
Repeat after me. I do solemnly,
I do solemnly,
sincerely and truly
declare and affirm
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth, the whole truth,
and nothing but the truth.
and nothing but the truth.
Thank you, take a seat.
Sorry you've had to wait so long.
That's okay.
Good afternoon. Good afternoon, Dr. Piper. Thank you for your assistance to the inquiry. Can we ask you to keep your voice up, speak into the microphone in front of you, and not to speak too quickly, so that stenographers can keep pace. If you need a break at any point, please just say so. You've provided 2 witness statements to the inquiry. The first one is dated the 17th of January 2024, and that's there on screen. And if we could just go to page 2, paragraph 6, please. I understand that there's a correction in this statement, Dr. Piper.
Yes,
you could
please.
please highlight that correction.
So the correction is in relation to the date on which I first met with the First Minister and Deputy First Minister. It should read the 27th of October 2020.
And then you have provided a second witness statement dated the 28th of March 2024. And I take it you're familiar with both of those statements?
I am.
And you provided a signature and statement of truth. It's on page 62 of your first statement. Please can you confirm the contents of that statement are true?
Correct.
And your signature and the statement of truth is at page 9 of the second statement. Please confirm the contents of that statement are true as well.
Yes.
Thank you. If I can just summarise your background as follows. So you joined the Northern Ireland Civil Service in 1985. You were appointed to the Senior Civil Service in 2003. You resigned in 2013 to take up the post of Chief Executive of the Utility Regulator. You remained in that role until October 2020.
Yes.
And as you just indicated, it was at that time that you were approached to take on the role of the interim head of the civil service.
Correct.
And that you took up that post on, was it the 1st or the 3rd of December 2020 that you took up
The
that
1st
post?
of December.
First. And then you served as interim head of the civil service for 9 months until Jane Brady took up the post on the 1st of September 2021. Is that
Correct.
One point just to clear up. When you took on the role of interim head of the civil service, there had been no head of the civil service in Northern Ireland between Sir David Stirling's resignation at the end of August 2020 and when you took on the role. Is that correct?
Correct.
Was there anybody filling the gap of head of the civil service in that window?
There was no one filling the gap as head of the civil service. I understand that a number of the senior staff, permanent secretaries, stepped up to try and provide support to the executive and also to carry on the work of the Civil Service Board and the Permanent Secretaries Group, but there was no one appointed or designated as head of the Civil Service.
You described the role of the head of the civil service as taking a holistic view of providing support to all executive ministers, and you also describe it as leading and pulling together joined up cross-cutting responses from across the civil service. Is that right?
Yes.
And in what way would you do that?
Well, in a number of ways. I made reference to the Civil Service Board, the NICS Board, which would have included all of the permanent secretaries and a number of additional senior staff, including the head of NICS HR, Human Resources Department. And that group would have met monthly to look at cross-cutting issues in relation to the civil service, resourcing, and the management and movement of staff. The Permanent Secretaries Group met every Friday and again would have been looking at issues right across each department. That would have been a stocktake meeting, looking at what was happening in every department, reflecting that back so that the head of the civil service would have an overview of everything that was the key issues that were going on in the departments. And that would allow the head of the civil service to have an understanding of the sorts of issues that the executive ministers might be considering as well.
Is it right that there's a slight tension between the role of the head of the civil service and the way that the departmental structure actually operates in Northern Ireland, to the extent that the responsibility that's delegated to individual departments and their ministers does rather work against the kind of cross-cutting holistic role that the head of the civil service has?
I think that's correct, and I think Sir David Stirling gave quite a detailed explanation of that to the inquiry yesterday, and his explanation would resonate with my understanding and experience. It does, and you refer to the tension, and I think that does leave the head of the civil service in a position of not being able to dictate to the permanent secretaries how they might operate or what their priorities should be. It also leaves, I think, the head of the civil service in a position of having to use soft power to, at times, encourage the reallocation, perhaps, of resources. And again, I think that's an issue that Sir David Stirling touched on yesterday when he referred to seeking volunteers to staff up the Civil Contingencies Group. That's one of the limitations of the model, that the head of the civil service is also permanent secretary in, or certainly at my time and in Sir David's time, was also permanent secretary of a department, the executive office, with delivery responsibilities in that office at the same time as trying to take that holistic view and represent the civil service as a whole. I hope I've explained that. Okay.
I'm going to tease a couple of those elements out, if I may. So one point is it's about using the soft power in terms of reallocation of resources. Is it right that the head of the civil service can't actually require or direct any action by any civil servant?
The head of the civil service operating in the role of permanent secretary of the executive office could exercise that authority in given the responsibilities for that department, the executive office, but could not do that in relation to other departments, because the permanent secretaries of each of the other 8 departments are all accounting officers and have a personal responsibility for the management and delivery of the resources underneath their command.
You say in your statement that you have experience of the reluctance of ministers and their departments to share resources and the inability of a head of the civil service to demand or impose flexibility. How kind of conceptually did that impact upon your ability to carry out your role?
I think where I found it particularly challenging was in some of the later stages of my tenure, after the COVID task force had been established and was up and running. And there were a number of difficult cross-cutting issues coming through, such as the managed quarantine arrangements and the establishment of a support scheme to assist travel agents. Neither of those issues, both were, well, certainly the managed quarantine was arguably had cross-cutting implications, but there was a sense that that probably was the responsibility of the Department of Health, and the travel agent scheme should, in the minds of many, have fallen to the Department for the Economy, which had responsibility for tourism. The difficulty arose because neither of those departments would accept responsibility for delivery of those 2 big initiatives, and my department, the Executive Office, was seen sometimes as a little bit of a dumping ground for cross-cutting initiatives, and those 2 particular areas were allocated with considerable reluctance to my staff. And when I tried to seek some additional resources to support my team in delivery of a grant scheme, not something we were resourced to do, and to a lesser extent the managed quarantine service, that's when I experienced the reluctance to release resources to the centre to help support delivery of those two initiatives in particular.
So effectively at that time you had two hats on. You were Permanent Secretary of TEO and you were Head of the Civil Service. So as Permanent Secretary you could allocate resources within your own department.
Correct.
But actually, as Head of the Civil Service, you weren't able to then direct anybody within the Civil Service, whether it be to TEO or any other department, in order to fill any gaps that arose. Is that right?
That's correct, and was a source of some frustration, I think, to executive ministers.
I can understand. I didn't know about this until this inquiry started, Dr. Piper, but I can understand why you have the system of the independent departments with ministers, because they're coming from the different political parties. But is there any scope for suggesting that may well be the right way to do it here in Northern Ireland, given all the sensitivities, but in a national emergency?
My lady, I would agree with that, and indeed for me it would be one of the reflections from my tenure that perhaps in the case of a national emergency, the head of the civil service could exercise some additional authority or powers in relation to brigading the necessary resources, whether that would be to manage and staff up CCG, or whether it would be to take forward some of those big cross-cutting initiatives. I think my team deserve a huge amount of credit for delivering, as do all of the departments. The Department of Health was exceptionally pressed, but it did show one of the weaknesses of what ministers and indeed the general public might have imagined was the case in terms of the extent to the head of the civil service could control all of the resources under his or her command.
So in terms of the specific examples that you've given earlier on, was there any other negative impact that arose from the fact that you weren't able to direct staff across the civil service, not just necessarily within TEO, but within other departments?
I think it was a regular frustration at the Permanent Secretary Stocktake Group that there were some departments under severe resource pressure, particularly the Department of Health, for obvious reasons. And the Permanent Secretary would have, at almost every meeting, have raised his concerns about how stretched and strained his resources were. And he, like me, was trying to exercise soft power and plead with other departments that if they had any staff that they could release, he could use them to take up the strain in the Department for Health. I think one of the problems with that that I faced was the difficulty we had in getting people who could do the necessary legislative drafting, particularly in very short timeframes. If the executive agreed changes, for example, to the guidance and regulations needed to be amended, those regulations were invariably public health regulations and required an understanding of not just how to make regulations, but also an understanding of the health regulations. And I think there was a paucity across the civil service of people with those appropriate skills, and therefore it was not straightforward to simply direct anyone that had legislative experience to work in support of the Department of Health.
If I can just jump in there. So is that a feature of the fact that there had been a series of effectively redundancy schemes, for want of a better phrase, in the years prior to 2020, in which you'd lost a number of older, more experienced civil servants who had legislative experience?
I think that's undoubtedly the case, but I would suggest that a further factor was the fact that we hadn't had an executive for 3 years until January 2020, and there had been no legislative programme being delivered during that time. So there were civil servants there during my tenure who had no experience of making legislation and doing the necessary work because there had been no executive for a prolonged period of time.
Because you set out in your statement that in June 2021 there were 4,000 unfilled vacancies in Northern Ireland Civil Service. What percentage of the civil service is that?
I wouldn't know that offhand.
Well, what was the impact upon the pandemic response in 2021 of 4,000 unfilled vacancies in the civil service?
Well, the civil service had been running with that level of vacancy for some time, and the Civil Service Board had been working through a process of trying to recruit more staff. But even recruitment during a pandemic, particularly during lockdown, was not straightforward. I think what the impact that it had was probably to place additional pressures on the senior cadre within departments in particular. I can't recall now, although the figures are available in minutes of the next board. I can't recall exactly where those vacancies lay. Many of the 4,000 might have been in the administrative grades, but certainly the strain, the slack, was taken up at senior level, and it was the principal officers and above that were bearing a disproportionate burden.
Thank you. If I could then just move to the state of the pandemic in Northern Ireland as at the 1st of December when you took on the role. So you commenced the role about 3 weeks after there'd been I think it's fair to describe, a lengthy and taxing executive committee meeting that commenced on the 9th of November and continued on and off until the 12th of November. Significant restrictions have been implemented in Northern Ireland that started on the 27th of November. Restrictions were going to expire on the 10th of December, and it wasn't known at the time that you started what those restrictions would be replaced by. Plans for Christmas 2020 were under consideration, and it was also believed that restrictions would be required after Christmas 2020. That's a very challenging set of facts to drop yourself into when you were appointed to the role of interim head of the civil service. Had you had any handover, introduction, induction into your role before you started?
I'd had some opportunity to put in place a number of familiarisation meetings in the first week of my tenure. And in addition, there was what the Civil Service calls first day briefing that had been prepared for me on arrival. The reality, however, was that I didn't know until the 24th of November for definite that I was taking up the post.
So you had a week?
So I had a week during which I was able to make contact with some former colleagues, make contact with some of the staff I knew would be running my private office.
Because in comparison, I mean, as you set out, Dr. Brady had a handover that lasted from about mid-June to the end of August 2021. Plainly, that's a very beneficial position for the head of the civil service to find themselves in, to have that handover, and it would have been a benefit of you to have something similar.
It would, but my understanding was that until First and Deputy First Minister had made a decision and then briefed the executive, which I understand was done on the 26th of November prior to the press release about my appointment on the 27th. Until that had been done, it wouldn't have been appropriate for me to have made contact or sought to have briefings with anyone. And as I say, I only received a draft contract on the 24th of November.
Given the circumstances that were in existence at the time that you took up the role, and given the fact that there hadn't been a head of the civil service for a number of months, do you think at that point in time Northern Ireland and the civil service was missing an experienced head of the civil service who would be able to use that soft power that you describe to potentially navigate a way through some of those tricky situations?
I can only speak with a degree of confidence about what I found from the 1st of December, at which point the Minister for Health and the CMO were providing options around restrictions, were providing very clear health, medical and scientific information. And I think as we moved through December, the extent to which Northern Ireland was facing a post-Christmas surge, I think that was known and was anticipated. Where I think ahead of the civil service might have been able to add value in the weeks preceding that, particularly around the time of that difficult, very difficult 3-4 day executive meeting. There might have been the possibility or scope for a head of the civil service to exercise some control or some processes around consideration of a range of issues. That was the point at which ministers were starting to really explore that tension between the impact on the economy and the health implications. By the time I started, they'd had that initial foray into a series of very ad hoc meetings. By the time I came, yes, we did have, as we went through December, particularly as we got closer to Christmas, we did have an increasing series of meetings after the 17th of December. I think the 17th of December...
If I can just stop you there, because we're slightly getting off the path.
Sorry.
If I can just bring you back in terms of the benefit of a head of the civil service. So, fair to say that the role of the head of the civil service, you have to be able to build effective relationships with ministers and permanent secretaries.
Indeed.
And you also have to know the relationships between the ministers and their permanent secretaries.
Yes.
You last worked in the Northern Ireland Civil Service 7 years before you took on the role.
Yes.
Did you have any of those established relationships with any of the permanent secretaries or the ministers, or were you effectively building them from scratch when you took on the role?
I think I knew all of the permanent secretaries. Some I knew quite well. I'd worked with some of them before. I knew a number of the ministers quite well. I'd worked with some of them before, particularly the First Minister and the Finance Minister, whom I'd worked directly for in previous roles. So I didn't feel that I was starting from absolute scratch with any of the permanent secretaries or the ministers, and indeed for some of them the work that I had been doing as utility regulator would have brought me into contact with them on occasion. So for example, the infrastructure minister would have been aware of some of the work I'd done with the regulator. So I don't think I was an unknown quantity to ministers or the perm secs or vice versa.
But in terms of the working relationships from within the civil service, as opposed to working with a regulator dealing with the civil servants or the ministers, in terms of the ability to build up those relationships and the understanding and the trust that takes, that took time.
It did take time, and I met all of the ministers with their permanent secretaries in the first few weeks of my tenure.
And do you think that there was any impact upon the pandemic response at the time it took you to build up those relationships?
No, I don't believe so, because ministers had already been working with one another and working with senior officials in the TEO team.
If I can then move to the preparations for Christmas 2020. So, is it fair to say that in December 2020, the primary consideration of ministers generally at that time was maintaining the ability of people to interact with their families at Christmas in 2020?
I think given what had happened over the summer in terms of the progress of the pandemic and in terms of the relaxations in the regulations that ministers had put in place, I think there had been a hope, probably from late summer, as ministers looked ahead, there had been a hope and a desire to be able to give people more of a normal Christmas if that were possible. They knew, and I think accepted, that that was dependent on the R rate. They had a desire to keep that under or at about 1. And I believe that they weighed carefully and talked at length, I believe, about the impact of lockdown, the impact of the prolonged restrictions, about the ability to maintain adherence to those restrictions. And I think they had a real concern for the impact of prolonged restrictions, particularly on some vulnerable groups. They were concerned about mental health. So they were weighing, it wasn't that they just said, oh, we all want to have Christmas. I think they were weighing carefully the implications for individuals, for communities, and for business sectors as well.
Okay. In terms of the changes that you brought about, I'm going to deal with the ECT shortly, the Executive COVID Task Force. Were there any other changes that you brought in that month of December, apart from the ECT, that you thought were necessary when you arrived as the interim head of the civil service?
I think establishing a clear separation between executive meetings that were considering EU exit matters and executive meetings considering COVID response, and separating those into, I think we took EU issues on a Tuesday and COVID executive meetings on a Thursday. That sort of discipline, I think, was one of the first things that I tried to reinstate. I also reinstated the weekly meetings with special advisors and weekly meetings with the ministers as well, that First Deputy and the head of the civil service. And for the executive at that stage, my attendance at executive meetings and the ability that First and Deputy First Minister gave me to speak to executive ministers about the task force was again something of a change. The normal situation would be that officials don't speak at executive meetings other than perhaps to clarify an issue or a...
Okay, so you're talking then about bringing back the weekly meetings. The implication of that is that those meetings had either ceased to happen or had happened less frequently. Had there been a bit of a drifting apart of the departments, and so they were more focusing on their own area of responsibility without somebody to pull them all together from the top?
I think that was, I think there was inevitably, I think, some of that, perhaps exacerbated by the fact that ministers were beginning to think beyond a collective response to the pandemic and beginning to think about their own departmental responsibilities and priorities. And that inevitably was provoking the permanent secretaries to focus on, on their ministers' other priorities, not just the response to the pandemic.
Okay. Well, that's going to take us conveniently through to the Executive COVID Task Force. You say in your statement that the First Minister and Deputy First Minister made it clear to me that the ECT was my first priority on taking up the interim head of the civil service role. How stridently was that view put to you, that that was your first priority?
I couldn't say that it was strident, but it was certainly mentioned to me by First and Deputy First Minister when I first met them on the 26th of October. They didn't talk in detail about an executive COVID task force, but they did indicate that they'd been giving some thought to a head of the civil service led task force to look ahead at the approach to lifting restrictions or addressing restrictions and starting the work towards recovery. So that was flagged with me as early as October.
Did they say why they wanted this brought in?
They did indicate that they felt there was a need to start and look at things not simply from the health perspective, but to find a means to consider other issues, particularly around the economy and what was happening in the community. And they felt that that could only be done because that raised cross-cutting issues. They felt that could only be done by a head of the civil service.
Was there a sense of frustration that they felt that they weren't receiving the information that they wished?
I think that's documented in a number of areas, including a minute of one of the meetings.
Well, should we pull that up? If we could have INQ 000391436. Thank you. So this is a meeting between yourself, the First Minister and Deputy First Minister on the 1st of December 2020. Is this the meeting that you were referring to in terms of it indicating their views and their thoughts at the time?
This is not what they talked to me about back in October, but yes, this is the meeting I was referring to, where they perhaps were more candid about some of their, I think you used the word frustrations, and I think that's reflected in this note.
Yes, I mean, how well do you remember the meeting? Because it's not a memory test. If you don't remember it,
No, I do remember it, and I recognise this note of the meeting, and I recognise it as reflecting the discussions that we had, and I think it does bring across the level of frustration that perhaps they were both feeling at the time, and it chimes with what they had said to me about needing a Hawks-led approach to make sure that there was a more balanced approach and better process put in place.
because there was, as it's set out there, the First Minister under the key points is looking for a more coordinated approach required, that they don't know what's happening. And then under the Deputy First Minister's points, left not knowing and left to front things. Again, are you able to provide any further indication of what they were thinking, or is that best left to us then?
Well, I mean, I know that they were frustrated that on a number of occasions the Minister for Health, and I think on one occasion the CMO, had been giving briefings to the press, as was normal and as you would expect. But
Just
information...
Did you mean that in terms of the joint press conferences or separate from those joint press conferences?
I mean those press conferences where the Health Minister spoke, or where the CMO in his professional capacity would have spoken. They indicated to me that there had been a number of occasions where information that they were unaware of was revealed to the media, and that had caused them considerable annoyance because they were the joint heads of government. So that, I think, is the reference to they don't know what's happening. And I think the reference to late papers and process really was a reference to some of the health papers that were coming through from the Minister of Health that were coming very late to the executive. The process would be that any papers to be discussed at the executive would be provided to the First and Deputy First Minister in the first instance, and then once they'd had a chance to consider them and agree the agenda for the meeting, the papers would be circulated to the other ministers. And if papers were late coming to First and Deputy First Minister, that then meant they were even later being circulated to the other ministers, which had the impact of sometimes causing the start of an executive meeting to be postponed. And in terms of process, the Deputy First Minister describes it as disrespectful.
Yes, and in fairness, the bullet point below is example of DOJ late issue given. So it wasn't entirely the Department of Health, but were you able to get a sense of where there was a primary or a more frequent source of their concerns about information not being given to them?
I think the primary source that was reflected to me would have been the Department of Health. However, I have to agree with Sir David Stirling, who reflected yesterday that the frequent leaking of executive papers did perhaps encourage some ministers to hold back their papers to the last possible minute before they circulated them. And there was a bit of poor process and poor behaviour, poor process and poor behaviour from all ministers.
You were talking there about leaking. So David Stirling was talking about leaking. There was a 3-month gap, 3-4 month gap between when Sir David retired and when you started. How long did the leaks continue for when you were in your role?
They were continuous. I would have to say that I felt as if all of those meetings in December, I felt as if we were living them in the media, because the timing of meetings seemed to be available to the press. Any delays, any postponements. I do think, if I may, I do think once the COVID task force got up and running and we got into a better process and a better rhythm, and I know we may go there, and there was a bit more certainty and predictability about when decisions would be made around restrictions, I think we did get an easement in the extent to which there were leaks. But there's no doubt in my mind that everything started up again, really between March and April. And, you know, there were political issues going on then, which I think were perhaps encouraging some parties to leak.
March, April 21?
Of 21, yes.
Those issues, they were non-pandemic related issues, is that right?
They were non-pandemic issues.
But plainly, when you have an executive committee of ministers, they're not focusing solely on pandemic related issues, and any issues that arise for non-pandemic matters are naturally going to have an impact upon the relationships they have with each other.
Correct.
And therefore it's going to have an impact upon the way decision making is taking place, is that right?
Correct.
So in terms of, you were talking about December, before the ECT got up and running, what was the impact upon the living the meetings in the media, as you described it, upon decision making of the executive at that time?
I think it hampered decision making because there was a breakdown of process and a breakdown of trust. I think it added to perhaps the sense of in the public loss of confidence in decision making. And that could have had other impacts as well in terms of public confidence about adherence and whether it was guidance or regulation. I think it didn't create the right impression.
As far as you're aware, did it have any of that particular impact in terms of adherence, or you just don't know?
I couldn't say at Christmas that there was any particular impact. It certainly made for a very intense schedule of meetings, and the chairs pleading with colleagues not to leak to the press. I'm not conscious of papers being leaked. I've no memory of papers being leaked, but certainly the timing and the rescheduling and the frequency of meetings, the press seemed to be aware, and it did add, I believe, to people's uncertainty about what was happening and what the guidance would be.
I want to move away from non-pandemic issues and go back to the setting up of the ECT. Was there resistance from any quarters to the setting up of the ECT?
My understanding is that the executive itself was, in fact, briefed about the proposition to set up a task force back in November, late November. And there was not resistance or opposition to that. I think there was a recognition that some fresh process, perhaps a step change in process might be valuable. I did brief the executive on the emerging structure and modus operandi of the task force on the 3rd of December. And there was pushback, particularly from two ministers, from the Minister of Health and the Minister for the Economy. Not an absolute pushback, but concerns were raised about how the task force would operate.
And what were the concerns raised by the Minister of Health?
I think his concern was that in some way the task force would dilute or seek to reinterpret the health information. Clearly the initial response to the pandemic had been health-led. And perhaps there was a concern that this move now to look at issues in a cross-cutting way would take a focus off the health aspect of the pandemic, which still remained hugely, hugely important. I think perhaps he and maybe some of his senior colleagues might have had a concern that there would have been some challenge to the integrity of some of the medical and scientific information coming forward, or perhaps some reinterpretation by non-medical experts within the executive office. And that was a concern I could recognise. I think he also was operating initially, at the time he raised the concerns, he was operating under a slight misconception that it was an executive office, a TEO as a department, a TEO task force. So TEO as the department, as opposed to the executive as a whole. In fact, the task force had the endorsement of the entire executive, and it was not a narrow departmental issue.
It seems like that the genesis of establishing the ECT was the First Minister and the Deputy First Minister wanting to have a little bit more knowledge and control of events that were coming out of the Department for Health. And is it right that you're describing their slight resistance from the Department for Health because they didn't want to lose that control over their own data and their own information?
I think that's fair, but I think it's also fair that the regulations were all within public health legislation, and therefore they did have that primus inter pares role, I think. So I did recognise and understand where the Minister for Health was coming from, and an early meeting with him in December, I think, was helpful in teasing out those concerns and reassuring him that actually the purpose of the COVID task force was to take information from all departments, see what they were saying, what proposals they might have around lifting of restrictions, almost as a triage exercise that could then be referred to the CMO and the CSA in terms of, if we did this, what might the implication be? So in fact, what happened was the task force operated and we actually built in the health input, and the health information still came as a separate paper with all of the information that they would have been providing anyway and had been providing. So it actually enhanced, I think it enhanced the information flow. And indeed, I believe the Minister of Health did recognise that in subsequent meetings.
And is that an example of the soft power that you're bringing to bear? That it's, even though you're talking about the legislation and the responsibility for the Department for Health matters, that you still had other ministers who felt that their areas of responsibility were being slightly pushed back on. And so it's not just a matter of process when you're a mandatory power sharing arrangement. You have to maintain the relationships between the ministers to make sure the executive is working as efficiently as it possibly can.
Absolutely.
And so is it right that that meeting that you had, I think as you described it, did that end up helping the situation in terms of the relationships between ministers as opposed to just the flow of information through the ECT?
I believe that it did. It certainly, I believe, it reassured the Health Minister, and indeed, within a matter of weeks, 5 or 6 weeks, I proposed the idea of the Health Minister joining First and Deputy First Minister for a pre-brief ahead of executive meetings, so that he had an opportunity to tease out with them any issues or concerns that they had, and also to make sure that his voice in terms of the medical and scientific position was being presented. And I believe that was really helpful to First and Deputy First Minister in their chairing of meetings. But it also, I think, reassured him that he was, still very much in a key position within the executive.
You had also mentioned the Economy Minister. It wasn't just about the Health Minister,
yes,
about resistance. Would you be able to describe what your views were of any resistance from the Economy Minister to the ECT? Were they similar concerns or were they different?
No, I think they were quite different. Although they may still have come from the same place in terms of the positioning of her department. I think her concerns were really about who would be leading recovery, and particularly recovery of the economy. She was concerned that that was an area that her department was leading on in terms of a new economic strategy, the 10X strategy. I think she expressed concerns about the COVID task force slowing things down and perhaps duplicating work that was being done elsewhere, or creating additional layers of reporting and bureaucracy that might divert her officials from driving forward with the economic recovery document.
In relation to those ministers, Health Minister is responsibility for the Department for Health, the Economy Minister is responsible for the Department of the Economy. Plainly, it is part of their role in order to advance the views of their department to the best of their ability at the Executive Committee, is that right?
Indeed.
And so did you end up bringing the ministers together again and actually having that little bit more cohesion as in the executive through the introduction of the ECT?
I think there was more progress with the Minister of Health in terms of cohesion. I think the Economy Minister remained throughout my time impatient with the pace of the lifting of restrictions as they applied to the business community, particularly as we got beyond Easter and a very strong call came from the hospitality and tourism sectors. I think perhaps she felt that some of her concerns were valid. But in fact, the COVID task force was not a decision-making body. It was a means of coordinating policy. In contrast to the CCG, which was looking at operational coordination, the ECT, the COVID task force, was looking at coordination of policy responses and trying to make sure that there was an overall coherence to the executive's response to lifting restrictions, and in particular to developing an overall executive response to recovery, in addition to what the Minister for the Economy was doing with the economic recovery.
Thank you. If I can move now to consideration of inequalities, probably into 2021. If we can have up INQ 000 411 509. And if we go to page 60, please. Paragraph 273. We can see there the extent of the impact of NPIs on different groups within society was not assessed in any systematic way during my tenure. Well, why not?
It's a very good question, and I think it's one of the key learnings for me from this process. Initially, I believe that the pace of decision making was such that it simply wasn't possible to do the normal Section 75 or EQIA reviews that would be a normal part of civil service process. We were unable, therefore, to consult in a short space of time in the way we would normally. But stakeholder engagement was very extensive, both before I came and also throughout my tenure. And I suppose that was our proxy for consultation.
But isn't it a difficulty when you say about proxy of consultation, that you are the government of Northern Ireland, you have access to different sections of information, and that it's incumbent on the government to be able to identify those sorts of information so that in a pandemic you have an understanding of the impact of the pandemic on different groups?
Yes, I wouldn't disagree with that.
Was there anything that you directed as the head of the civil service about any steps that could have been taken in order to ensure that there was a greater understanding or assessment of the impact of NPIs on different groups within society, as you include in your statement?
Well, both ministers, both the executive and the COVID task force, did consider the impact of restrictions and indeed of lifting restrictions on different groups as we worked through our process, and particularly in relation to the COVID task force. Some of the work on adherence and behavioural insights did delve into what the implications were for particularly vulnerable groups. I think the point I was trying to make is that we didn't do it in any systematic way during my tenure, and that an opportunity, I would say, an opportunity was missed by the COVID task force to perhaps have an equality work stream that would have given some focus to the work that was being done in terms of stakeholder engagement, but also the work that was being done by individual departments with their stakeholders. So I'm thinking perhaps of the Department for Communities with disadvantaged communities and with low-paid families. I'm thinking of the Department of Health in relation to all of the information that was coming through from the Public Health Agency and in particular from the trusts. Huge amount of information from the social care system. That information was, I think assumptions were made that information was being considered and assessed by departments and was factoring in and featuring in their individual departmental responses. I think we missed
apologies to cut across you. Just, I'm conscious of the time that we have. In terms of the assumptions that were being made, was there anybody within the ECT who was suggesting that more should have been done to make a systematic assessment, or was it effectively a collective assumption that sufficient was being done elsewhere?
I couldn't say that there was anyone in particular, which is why on reflection I would say we missed an opportunity, and we should have taken more care and made greater proactive efforts to make sure that all the voices that should have been heard were in fact heard.
Because if I can just take you to, it's the document Moving Forward, the Executive Pathway Out of Restrictions. It's INQ 000 104467. I presume you remember this document quite well. It was published on the 2nd of March 2021. This was intended to be a public-facing document.
Yes.
And so it was intended to communicate the executive's thought processes, plans, intentions to the population of Northern Ireland. If we can go to page 6, please. In terms of the societal impact there, you can set out that the pandemic and restrictions had an impact upon physical and mental well-being. It then moves into issues in relation to housing, sports, arts and culture, and then down into the next page, please. The financial impact in the top left corner has been heavy for many people, with increased levels of unemployment, and then across society it would be difficult to imagine anyone who's not been negatively impacted by this pandemic. On reflection of this framework, do you consider that there is sufficient attention given to inequalities and impact upon the population of NPIs? Or do you think that on reflection more should have been included in there, given it was a public-facing document?
I think it would have been, with hindsight, it would have been better to draw out some of those implications and those impacts more clearly in that public-facing document, which was intended to be a communication to explain to the public how the executive's process was working. And in a way that was an attempt to try and deal with the concern and perhaps any loss of public confidence about how the executive was working. I would say to you that we did learn from the engagement that we had with the stakeholder groups, and when we came to develop the recovery document, the Pathway Out of Recovery, which was published in August 2021, one of the key work streams, I think we described it as a recovery accelerator. One of those themes was tackling inequalities, and that was an explicit recognition of the disproportionate impact that the pandemic had had on various groups and various sectors. And it was a recognition that there were specific streams of work that would need to be taken forward as we moved into recovery to address those impacts and those inequalities.
That framework building forward, it was criticised by the Equality Commission, is that right, for not paying sufficient attention to Section 75 duties?
I understand that, however, that postdated my tenure, but that was the first document that we put through the formal EQIA process, and I'm aware that it was criticised, yes.
And in truth, that building forward COVID recovery plan was published on the 2nd of August, but it had started consideration back in March 2021, so it was about 5 months in the making, is that right?
It was.
I want to move now to WhatsApps. You say in your statement that you've had no experience of any key decisions relating to the pandemic being made during informal or unminute discussions, and no messages were deleted by me or on my behalf regarding how the public in Northern Ireland approached the response to the pandemic. Is that true?
It is true.
Okay. So you, in your original statement, and if we can have up 411509, page 47, and it's paragraph 212, and you set out there, on the day of my departure for the interim head of the civil service role on 3rd of September 2021, I returned my NICS mobile phone and laptop and have had no access to either device since. I had deleted nothing from them and had no informal messages on any other personal device. Give you the opportunity to explain, Dr. Piper, is that accurate?
It is not correct, and that's why I made a second statement on the 28th of March to correct that assertion.
And so your further statement says that, contrary to what I stated in paragraph 212, I did delete material from my work and personal devices. Joining those two limbs together, you're saying that you did delete some material, but you're also satisfied that you didn't delete any material about the government in Northern Ireland's response to the pandemic. Is that right?
I can only be clear about my personal phone, because although I returned my civil service, my work phone, when I left, and I did not reset that phone, I learned on the I think it's the 13th of January that device could not be located. So I can't speak confidently about my work phone. But my second statement does set out the circumstances of deletion of material from my personal phone, and confirms that that material was not related to the COVID inquiry or not related to the pandemic response or to decision making.
Yes, if we can have up INQ 000 421 746, please. It's page 6. And paragraphs 25 to 27, I'm not going to go through them, but that sets out your understanding of the circumstances of that led to the deletion of that material.
It does.
And so you say that you were not advised by Jill, so that is Jill Milne.
That's Jill Milne.
And she's the head of NICS HR, is that correct?
She is.
And you say that you were not advised to delete messages, but you were advised about appropriate and acceptable behaviour. That's what you say there in your statement.
Indeed.
If that was the advice that you received, why did that lead you to, in words of a message that you sent, why did that lead you to clear out all of your WhatsApps and messages on your personal phone and your work phone?
I did not clear out all WhatsApps and messages on my personal phone. I deleted the exchange with Dr. McCormick because I believed that I had shared some casual and offhand comments on what was a personal communication channel, but I believe those comments on reflection were unprofessional. I don't believe that I consciously thought that those messages needed to be retained, but having spoken to Jill, I reflected that my communications with Dr. McCormick had drifted towards the inappropriate.
Just in terms of accuracy, if I can take you to INQ 000378038 for the reason why I talk about clearing out WhatsApp messages. So if we can scroll at the top there, so it's that message there, 17th of May 2021, 1949:35. On Jill's advice, I have cleared out all my WhatsApp and messages on this and my work phone. So are you saying that you didn't actually clear out everything, you just cleared out aspects?
I did not clear out everything, and a number of my exhibits confirm that there were other WhatsApps exchanged. Very casual, especially when you read it now, knowing what has happened in relation to the loss of information. There was nothing more than I suppose the conversation with Jill was nothing more than a reminder about not using informal channels for casual conversations. And I regret now that I deleted anything from my personal phone, because I believe that it could have led or given the impression that in fact I had deleted more than I had.
You were aware at that time of the need for accurate retention of records?
I was aware of the civil service guidance at the time, yes.
And in terms of the timeline, so that is dated the 17th of May 2021. So it was on the, if we could just have INQ 000409662. So this is the 10th of June 2021, so it does post-date the messages that you sent in terms of the letter from the Director General Proprietary and Ethics of the Cabinet Office about recording records in relation to the Covid-19 independent inquiry. And you saw that letter from the Cabinet Office, and,
I did.
And you circulated it around Permanent Secretaries in...
I did.
And what steps did you take in response to this letter to ensure that information was secured across the Government of Northern Ireland or the Executive Office to ensure that all records were retained that might be relevant to the inquiry?
As you have said, I did circulate that guidance to all Permanent Secretary and senior TEO colleagues. I drew specific attention to the need to secure information and reminded Permanent Secretaries about the fact that this might raise governance issues for their, I don't think I explicitly said audit and risk committees, but it was in my intention was to ensure that their governance processes were cognisant of the likelihood of Northern Ireland joining this inquiry. At the time, Northern Ireland had not committed to join the inquiry. The Deputy First Minister had not agreed that we would be part of it, but I think the assumption was that we would form part of that inquiry. I did draw specific attention to the requirements in that memo. But Permanent Secretaries are accounting officers and accountable for their own staff and their own resources. And frankly, I felt the responsibility, the primary responsibility lay with them to ensure that proper procedures were followed. I did talk with my own accounting officer because although I was the permanent... I'm sorry.
No, apologies to cut across you. I'm just conscious of time. As far as you're concerned, you received this letter in and around 2 weeks after that you deleted those messages. Are you satisfied that the messages that you deleted didn't have any relevance to the COVID inquiry?
I cannot speak with authority about when I deleted the messages, but because the action point is noted in my own notebook, I believe I deleted them before the 10th of June.
My lady, I have no further questions.
Thank you. Does anybody else have any questions? Mr. Freedman.
Dr. Piper, I asked questions for disability action, and I want to raise a matter with you in the knowledge that you very understandably did not have the luxury to read into your role, and we've heard that very clearly this afternoon. But as to what you found on the 1st of December, would it be right that you were initially dependent on what was flagged up to you and what had sufficiently left its mark in the everyday workings of the Executive Office to otherwise be clear to you?
I think that's an accurate statement, yes.
Now, at paragraph 276 of your statement, you just give a personal sense that the impact of the pandemic on certain groups within society only really began to emerge, at least for you, as 2021 progressed. And you may recall you referred to the Sarah Everard event in London, then triggering your own awareness of things going on in Northern Ireland. That's a context for what I'm about to ask you. But therefore, given you coming into the job at 2020, at the end of 2020, does it follow that you were not aware of or otherwise briefed about following reports in relation to disabled people? I'm going to give you a list, and it may be no to everything, but if I may. In May 2020, the Cabinet Office in London, the Disability Unit, published a paper entitled The Impact of COVID-19 on Disabled People, and it made its way to the Executive Office. We know that. Did you ever see that?
No.
No. In June 2020, the Northern Ireland Council for Voluntary Action published a report on the impact of COVID-19 on carers in Northern Ireland. Did you ever see that?
No.
In September 2020, Disability Action, the DPO in Northern Ireland that I act for, published a report, The Impact of COVID-19 on Disabled People in Northern Ireland. Did you see that?
No.
Now, that report followed UK-wide reports on the impact of COVID-19 on disabled people published in July 2020 by the Office of National Statistics, and I'm wondering whether you saw that.
I'm afraid I didn't see that either.
Well, it's not a criticism. Just to clarify, then, the last would be in December 2020, the House of Commons Women's and Equalities Committee in the UK Parliament published the report of Unequal Impact, Coronavirus Disability and Access to Services. Did you see that?
No, I did not.
So really picking up on your acknowledgement about the learned lessons about not having a systematic approach to analysing adverse impact. Is that a set of at least reported impacts on disabled people that haven't been obvious to you when you've come into your office, haven't been flagged up to you, haven't made their way into sort of the everyday thinking of the Executive Office that could, if there was a more systematic way of approaching of these things, have been at least more embedded in the Executive Office? Would you agree with that?
I would agree with it, and it's why I said what I did around the COVID task force. Yeah. And with hindsight, the benefit of having an equality work stream within the COVID task force to look at those sources of information, to be a point of direct contact for disability action, for the Commissioner for Older People, a central point of contact, as opposed to relying on sources of information held in disparate parts of the system.
Yes. Now, my lady, I did ask for one follow-up question.
I gathered. Don't worry, carry on, Mr.
I'll carry on. That's very helpful. And I just wanted to then follow up on engagement, as you fairly put it, being a proxy for proper consultation. And I didn't hear you to say anything other than that would be a second best. But I just want to ask you about engagement. You may know, but my clients do not believe, and they give evidence about why they were not properly engaged with as a DPO. I don't want to ask you details about that. Your impression was that there was extensive stakeholder engagement. You've spoken about that this afternoon. It's in your statement. Now, just in terms of how that processes into final government product, are you aware that disabled people are not mentioned at all in the moving forward strategy for March 2021?
Yes, and that has been put in front of me as part of the hearing today. Yeah. And they are not mentioned explicitly. I would just slightly push back that the moving forward document is not a strategy. It is an explanation of the process that was going to be followed by the executive. But I absolutely accept that there wasn't anything explicit within that process that referred to engagement with people with disabilities or their representatives.
Yes. I understand what you accept, and I understand the slight caveat. Of course, the COVID recovery plan was a plan, and disabled people or people with disabilities are only mentioned once in that document, and that is with regard to enhancing their skills so that they can gain more employment. Now, that may be valid, but just in terms of engagement not really leading to enough in terms of important flagship government plan product, would you agree that's just not enough, and therefore whatever engagement went on, it just wasn't good enough and not a sufficient proxy, to use your words?
I would absolutely agree that we should have made more efforts to make sure that we had a more inclusive process and that the voices of people who should have been heard were heard and reflected in the documents. Yes, I would agree.
Thank you. Thank you, Marlene.
Thank you very much, Mr. Freeman. Thank you very much, Dr. Piper. Very grateful for your help.
That's
it for today.
Yes.
10 o'clock tomorrow, please.
All right.